Good morning, everyone. My name is Ann Joseph. I'm one of the program leaders for SPECS, and it's my pleasure to introduce our speaker today, Deanna Teoh from GYN Oncology. So Deanna is a member of our program and did her medical training at the Medical College of Wisconsin, OBGYN residency at UCSF, and then Gyne-Onc fellowship at Duke. And she's been here as an assistant professor at the university since 2011, I believe. Is that right? And her interest is in cervical cancer screening, and I think that's what you're going to be talking about today. And in particular, I think adherence or non-adherence to new guideline changes in recommendations for how we do cervical cancer screening. Also, other topics related to cervical cancer prevention, like HPV vaccinations. So we're happy to have you speaking today, and welcome.
Okay, so thank you all for coming, especially since it is freezing outside. So as Dr. Joseph said, I'm going to talk about optimizing cervical cancer prevention. Specifically today, I'm going to talk about screening, although I do some work in trying to increase vaccination as well. I have no disclosures that are actually related to this talk. So in 1948, the Greek physician and scientist Dr. George Papanikolaou published his findings that he could actually tell the difference between cancerous cells and normal cells of the cervix using a brush. And following this, in the 1950s, the United States implemented a cervical cancer screening program using the Pap test. And so what you can see is that from 1950 to the present day, we've actually drastically, by 70%, decreased cervical cancer mortality. And we've done this primarily through identification of precancerous lesions, which if we treat, actually we can prevent most cervix cancers, or by identifying early-stage cervical cancers where the 5-year survival rate is well over 90%. Now, interestingly, the sensitivity of the Pap test is only 50 to 80%. So the 50% was our old generation of the Pap test where we actually took a brush of cells and put it on a glass slide and you put this fixative on it. And the sensitivity has increased somewhat to about 80% with what we now use, which is liquid-based cytology. If you look at other screening tests, they're much more sensitive. And the reason that we've been so successful with such an insensitive test is that the natural history of cervix cancer is actually really long. So if you look, it takes a couple of decades to even go from precancerous lesions to cervix cancer. So what we did is for years with a test that only has sensitivity of 50%, we tested people every year. So even though each test, you had a 50% chance that you were going to miss a precancerous lesion, if you tested them every year, over time, there was a high chance that you were going to find those precancerous changes and actually still treat those women before they actually developed cancer. Now, even as far back as the 1950s, there was a lot of interest in cervical cancer being caused by some sort of infection. And actually, Dr. Papanikolaou thought it was going to be the herpes simplex virus. In 1984, we actually finally figured out that wasn't true and found that the human papillomavirus, or HPV, was the causative agent of about 98 to 99% of cervix cancers. Now, between the 1980s to today, we've actually learned a lot. So I remember in my training learning that once you had the human papillomavirus and you're infected, you would have it for your life. And so we thought that these women would always be at risk for cervix cancer. And what we've learned over the last couple of decades is that that's actually not true. So there will be 14 million Americans infected with HPV this year, but 90% of them are going to clear that virus within 1 to 2 years, and these women will not get cervix cancer. Even among that 10% who have a persistent infection for more than 2 years, if you keep watching them, about 40% will still clear the virus, and they also will not get cervix cancer. Now, among those who do not clear the virus over time, about 30%, so those who have a precancerous lesion, which we often refer to as high-grade dysplasia, will develop cervix cancer. So take it another way, among those who have a persistent, and we usually describe persistent as more than 2 years, HPV infection, 50% will develop cervix cancer. But among all those women who are infected with HPV, only 5% will develop cervix cancer. Now, how do we prevent cancer to begin with? So when we find these precancerous lesions, the old standby is actually just to remove a piece of the cervix. So it's something we call the cone biopsy, where you actually cut out a piece of the cervix. This is an invasive procedure. It's actually a very effective procedure. We can take someone who's at a 30% risk of cervix cancer and drastically reduce it. And I don't see this changing. We've had a lot of trials where we've looked at medical interventions to clear these precancerous lesions, and they just have not been as good. So I don't see this invasive procedure going away because for those who really need it, it's actually a very good treatment. So a lot of our efforts are going into really identifying those women who are truly at risk of developing cervix cancer and treating those women, while those who have a high chance of clearing even these precancerous lesions, not treating them and subjecting them to these procedures. So what are some of the harms of overscreening? So I don't want to undermine, the benefits of screening, because as you saw before, we've drastically decreased both incidence and mortality of cervix cancer. But when you overscreen and overtreat someone, there are risks as well. So I think the most obvious is cost. Right now there's a lot of talk about, our healthcare costs and not being able to maintain that. And so what we need to do is actually decrease the spending on things that are not going to make a difference in our population health. Preterm deliveries for a woman who are of reproductive age. When you cut out a piece of the cervix, you actually double their risk of a preterm delivery, and that risk goes up if they actually have multiple procedures. So unfortunately, there are some women who not only have one piece of their cervix removed, but over time have 2 to 3 excisions. Pain and discomfort. So again, this is an invasive procedure, and although compared to some of the larger surgeries you do, it's a relatively small procedure. It still does cause some discomfort, some pain. Bleeding and discharge, even if it's minor for any woman or anybody who's gone under any procedure, sometimes that can be really anxiety-provoking. Any procedure we do, there are surgical risks. So although, in our field we consider this a minor procedure, there is a risk, associated with any procedure we do. For some women, we've removed so much of their cervix, our only opportunity to prevent it is actually to do a hysterectomy. And hysterectomies do increase the risk of pelvic organ prolapse and urinary incontinence, which for a lot of women can be significant quality of life issues. And then there are studies that show that, having abnormal test results, having treatments can increase anxiety and even decrease satisfaction with their partners. And then there's a conditioned disbelief of results. So for some of these women, they're going to have these abnormal screening tests over and over again, and then they do their diagnostic test and it turns out normal. So you'll sometimes see patients show up into your clinic who say, yeah, I had an abnormal result, but they always turned out normal, so I stopped coming back in. Or stopped screening altogether because they became so disheartened with having these abnormal results that turned out to be nothing. They actually stopped getting the screening and then end up sometimes with actual precancerous or cancerous lesions. So this is a study that was actually done in Scandinavia that looked at the harms of overscreening. So it was a survey study that just asked women who are undergoing screening tests and then diagnostic tests what their experience was. And so what you see is even from a Pap test, when they looked at symptoms that lasted up to a week, 13% reported symptoms such as pelvic discomfort, urinary discomfort, feeling sick, feeling dizzy. Having done a lot of Pap tests, I'm not sure how much can actually be attributed to the test, but I think as we're learning more and more, as we start looking at patient-reported outcomes, patient satisfaction scores, whether or not it was the actual test that physically caused these symptoms or whether that's a patient's perception, those are important things to take into account. For those who had an abnormal test, anxiety lasting up to 3 months, approximately a third reported that, and that even persisted for patients who then had diagnostic tests that was normal. As we increased our invasiveness, so punch biopsies, then we started looking at pain, discharge, and you see that about half of patients reported that, and about 80% reported some sort of bleeding, even if it was minor. And then as we go to treatment, where you're taking out bigger pieces of the cervix, you can see that pain, bleeding, discharge, not surprisingly, those rates increased. So the objectives of my talk today are to illustrate the benefits and the risks of overscreening and overtreatment. And hopefully I've convinced you that there is a reason not to overscreen or overtreat in the first couple of slides. For the rest of the presentation, what I want to demonstrate is the prevalence of overscreening and overtreatment and the effects of an intervention to decrease such practices, and then to discuss some cervical screening populations for whom additional study is still needed. So, based on our knowledge of the disease, so knowledge that we can actually clear HPV, knowledge that, especially at the younger ages, in 2012 there was a new set of guidelines that were issued, and these were monumental in a number of ways. So this was the first time that actually all the organizations who make cervical cancer screening guidelines came up with a unified set of guidelines. So the idea was that it was actually going to be a lot easier to follow, because instead of having ASCCP and USPSTF and all these who had slightly different guidelines, all the guidelines were essentially the same. This was also the first time that co-testing, so PAP plus HPV testing right up front, was introduced. And what that resulted in was a significant lengthening of the interval between tests in women aged 30 to 65 if they had co-testing. So previous to this, we did yearly testing for a long time. Then about 2003 to 2006, we started introducing every 3-year testing. 2012 was the first time we actually introduced a 5-year interval. These are the guidelines that remain in place with one addition. So in 2018, USPSTF actually updated their guidelines and now have added an option of primary HPV testing every 5 years. Because what we found is that actually primary HPV testing is pretty much as sensitive as co-testing. ASCCP is updating their guidelines right now. We'll probably include that. Everything that I'm going to talk about today is primarily looking at either cytology or pap testing alone or co-testing. So are we following the guidelines? So, looking at some previous studies that have been done, which are primarily survey studies, we knew that overall providers were not following the guidelines based on both provider and patient reports. So this was a claims database study done in 2013, and what it showed is that 57% of women, or over half of those women under 21, were still being screened, even though guidelines going back as far as 2003 recommended against screening in women under 21. And then there was an NHIS survey, and again, this was done in 2010, so before those 2012 guidelines, but actually the guidelines for women over 65 and post-hysterectomy had not changed since 2003. And what they found in a patient-reported survey is that over half of women over 65 were still reported being screened, and about a third of women post-hysterectomy reported being screened. So in 2013, we actually did our own survey here among Health Partners providers. And the reason that we chose Health Partners is that's a HMO, and there's a lot more unity in guideline adherence, or at least what's recommended among the practice, as opposed to like Fairview, we've got these independent clinics which may all operate very independently. And what we found in that provider-reported survey is that they were very good at following the guidelines in women under 21 and those who were post-hysterectomy. About 3/4 were good at following the guidelines in women over 65, and where a lot of the confusion actually came in are those women who were over 65 who had new sex partners. And about 2/3 were doing every 3-year cytology in women 21 to 29, where we found a lot of confusion was adding HPV testing. So that's actually contraindicated in the guidelines, and there was a lot of confusion a year after these new guidelines came out on whether or not you do primary HPV testing in this younger age group. 30 to 65, what we found is that 90% were correctly screening with every 3-year cytology, which isn't that surprising given that it was actually a carryover from the previous guidelines. But we found that just over half who were doing co-testing, so the PAP and HPV testing together, were doing it correctly. A lot of people were doing it, but doing it at every 2 to 3 years instead of every 5 years. So with a more sensitive test, the idea was that you could do it less frequently. And what we found is a lot of providers a year after the guidelines came out were using the same interval, just adding the second test. Now, what we know is that when you do a survey study, among providers, a lot of us think we're doing one thing, but if you actually were to pull all of our records, we're actually doing something else. So what we did is we actually looked at practices at Fairview Health System and UMP to see what people were actually doing. So we had this survey data, and now we were going to look at what was being done. So we looked at all women between the ages of 30 to 65 who had PAP tests in our system between 2014 to 2015. And what we did is we looked at women who had had a PAP test at an interval of less than 3 years. So we figured with co-testing, it would be every 5 years. But even if you did cytology alone, really there's no recommendation for anything less than every 3 years unless you're following up an abnormal test. Because there are so many, we randomly chose to manually review 30% of the charts. And so that ended up being 3,300 PAP tests or charts that were reviewed. And what we found using very conservative criteria, so if we could not absolutely determine that the PAP test was not indicated, we counted it as indicated. So we found that even using conservative criteria, 70% of those PAP tests were not indicated. Probably the most common reason, besides just that a lot of people are still doing even every year testing in Fairview, is that there's a lot of confusion over what to do with those previously abnormal tests. So ASCCP actually has very detailed management guidelines, but it's very confusing. So a lot of people would just keep PAP testing these people. And what we also found is that there wasn't a lot of HPV testing happening, at least co-testing, which is actually the recommended screening strategy. We also collected data on women 21 to 29, and currently that data analysis is in progress. We also looked from 2012 to 2014 at those populations who should not be screened. We thought that this was actually the easiest population to look at, because if you look at the guidelines, women under 21, regardless of sexual history, women over age of 65, and then women post-hysterectomy should not be screened as long as they are average risk. And what we found when we pulled all the PAP tests that were done in each of these groups is that somewhere between a third to half of all the PAP tests done in these groups were not indicated. And for those under 21, we actually counted anybody within 6 months of their 21st birthday as indicated, because we know that young adult population actually don't come into the clinic very often. So we figured, from a practical standpoint, if you're seeing someone who's 20 and a half, there's a good chance you're going to do it because you might not see them for another 5 years. We then wanted to see what happened to these women. So these are the women who, if you look at the guidelines, should not be screened. And we wanted to see how many of them had abnormal results and then what happened to them afterwards. So what we found is that of all the women under 21, over 65, or post-hysterectomy who should not have had a PAP by the guidelines, that somewhere between 4% in those under 65 and as high as 14% in those under 21 had abnormal tests. Now this variation is actually not that surprising. So what we know is that in women under 21, they're actually at very high likelihood of having abnormal tests that are going to actually resolve on their own. We then looked at costs. So what we did is we calculated the cost for all these excess Pap tests, and we actually just looked at primary Pap testing, not co-testing. So what we found is at this time, actually very few providers were doing co-testing. So if we had added the primary HPV test, it probably would have increased the cost. But we looked at primary Pap testing. Then we looked at all the women who had abnormal test results and using the ASCCP management guidelines. So we assumed that once someone had an abnormal Pap, that they were getting their management and their diagnostic testing per the guidelines, and we added those costs in. And we basically came up with an excess cost for each group that ranged anywhere from $35,000 to $77,000 from anywhere between 2 and 5 years. And so what we found is that an excess cost of over $167,000 over 5 years, with most of that cost actually incurred in the first 2 years. Now, when you look at this, you look at healthcare costs in general, $167,000 is actually not that much. But when you think about it, what we're finding in our study, when we both did our survey study at Health Partners as well as our chart review here, is that what we're seeing in national surveys, our overscreening rates are actually very similar to what people are doing around the country. So when you start multiplying these costs across hundreds of healthcare systems across the country, that's actually a place where we could cut costs, presumably without actually affecting patient outcomes. So the last thing we did, and we had only short follow-up because this study was published in 2000, it was ultimately published in 2018, but finished in 2017, is we looked at these women who had, Pap tests over the next 2 years to see how many of them actually ultimately ended up with high-grade dysplasia or cancer, because that's really the outcome that we're trying to prevent. And what we found is that there were 2 high-grade dysplasia diagnoses that would not have been found otherwise. So both of these are women who had hysterectomies. Both of these were high-grade vaginal dysplasia diagnoses. So if you look at how much we spent over 5 years per excess diagnosis that we would not have found had these women followed the guidelines, it's about $84,000 per diagnosis. Now, I'm sure at the time, the patients and the providers were thinking, wow, I'm really glad I did that test because we found this high-grade dysplasia. One thing to keep in mind is that vaginal dysplasia is very different than cervix dysplasia. So when you've got high-grade cervical dysplasia, there's a 30% chance of developing cervix cancer. The data on vaginal dysplasia shows that the positive predictive value for high-grade vaginal dysplasia is only 0 to 9% for actually developing cancer. So there's a good chance that even had these not been diagnosed, that these women would not have developed vaginal cancer just because it's a much rarer cancer. So why do providers not follow the guidelines? So one of the things that we found both in our survey study as well as other survey studies is lack of knowledge of the guidelines. So these guidelines have changed every few years. As I alluded to previously, prior to 2012, there was no unification, so there were slight differences between the different groups making the guidelines. Patient requests, so for years we trained women to get your Pap test every year, and then suddenly we started pulling back, first to every 3 years and later to every 5 years. And there's a perception that less screening is risky, so a lot of people don't understand sensitivity, specificity, and the fact that we added the HPV test, which significantly increases the sensitivity, and that means you don't need as frequent of testing. Unfortunately, these guidelines were also developed at the same time that there was a lot of discussion about the Affordable Care Act. So there's a perception out there that we actually have decreased the screening because we just want to save money. And I think that this is especially true anytime that there are disparities involved, and that includes women's health care. A lot of gynecologists especially are worried about decreased reimbursements for healthcare maintenance exams. So OB-GYN has really become a specialty field. We're no longer doing diabetes management or anything else. And if we start doing, fewer well-woman visits, fewer, cervical cancer screenings, I think there's a question on what are gynecologists actually going to do. Pay-for-performance programs, which we often think are going to help, improve adherence to the guidelines, actually often reward overscreening. So a lot of times if you look at how things are measured, it looks at, if the guideline is every year or every 3 years, how many people have had that test within 3 years. And what they count as, not adhering to, your program is if you have a proportion of women who are getting screened at 3.5, 4, 5 years. And so actually, in Minnesota, they actually publish every couple of years these reports where we look at by clinic, they look at all sorts of things, region of the state, cervical cancer, colon cancer screening, breast cancer screening. And so actually a couple of years ago, I got to look at the report, and they publish everything. So they rank every, clinic in the state from who's actually meeting the guidelines and who's not, who's actually increased their performance and whose performance has actually decreased. And it was interesting because University of Minnesota was ranked probably in the upper third as far as following the guidelines. but they were actually listed in that group that was actually becoming less compliant with cervical cancer screening guidelines. And what they counted was every 3 years screening. And I actually had an opportunity to talk with the person from the Minnesota Department of Health who, collected this information and helped report it. And I asked if it was possible that we're doing more co-testing at the University of Minnesota, where the guideline is actually every 5 years. So if you use your metric of every 3 years, we looked like our performance was actually decreasing. And he had no idea that was even the case. So again, if you're measuring it, it looked like University of Minnesota was getting worse when it's unclear if that's really true. And then confusion over screening after an abnormal result. So if you think that the screening guidelines with all the categories was confusing, when you start looking at management guidelines and exactly what their abnormality was and how many past abnormal tests they've had, it becomes even more confusing. And so, when we have 10 minutes, 15 minutes with a patient, if you don't know, a lot of times people will just do a test because they don't know what else to do. So let's look at patient requests and the fact that less screening could be risky. And one of the age populations I think is most controversial is those women who are over 65. So this chart shows, based on SEER data, the distribution of cervix cancer diagnoses by age. And what you see is that the majority of cervix cancers are going to be diagnosed in women who are between the ages of 40s to 50s, and then it decreases significantly after that. But if you take this, agglomeration, women over 65 is going to account for 19.6% of the diagnoses. So some people have raised the concern that, that's almost 20% of all your cervix cancer diagnoses. Do we need to continue screening women over the age of 65? So this was a chart that's often used, and it's looking at the age-specific incidence of cervix cancer, so by age. And what you see is that, at least in some populations, as you get older, that risk actually increases. And if you look specifically, this is looking at the Black, population specifically. I do think that this speaks to the fact that, if you look at the guidelines, if you have not been adequately screened with negative screening before age 65, you actually don't age out. So I do think that if you look at any of these database studies that show this high incidence of cervix cancer after age 65, what they don't account for is what was their screening before 65. And I think that this chart does speak to the fact that potentially, especially because it's a minority population that tends to have lower screening rates to begin with, maybe our efforts need to be focused on screening these women when they're in their younger ages rather than, screening everybody over 65. But I do think that sometimes when you see these increases, it does cause concern. The other thing is that this guideline was made based on the fact that even if you get a new HPV infection at age 65, because it takes on average 20 years to develop cervix cancer, the average life expectancy for women is about 81 years, then most of these women are going to die of something else before they get their cervix cancer. And this is basically an age distribution chart from the CDC, and what you'll see is that there are approximately 46,000 women currently surviving to over 86 years of age. And of those women, because they tend to be healthier, their average life expectancy is an additional 6.5 years. So I think that you could argue, well, as far as life years saved, screening these women or preventing their cervix cancer, you're not saving as many life years. But for those of us who treat cervix cancer, we know that this is an extremely painful cancer, and even if you only had 6.5 years left to live, regardless, cervix cancer is probably not the way you want to die. There's also a changing sexual landscape. So the baby boomers who are aging into this population were part of the free love era of the 1960s and 70s. And what this means is that at the age where they were most susceptible to HPV infection, a lot of these women had multiple partners. There's also a rising divorce rate, as high as 50% in some populations. And so as women divorce earlier, they're more likely to have more partners over their lifetime. And I think that we've also underestimated how sexually active adults are. So a recent sexual health study showed that more than 40% of women 60-plus years of age and 20% of women 70-plus years of age are engaged in sexual intercourse. And if you start adding other sexual activities in there, that rate's going to increase. And in fact, what we're seeing is that in some of these aging communities where, you have, it's kind of like the new dorms, so we're seeing actually those are some of the fastest growing HIV rates and chlamydia rates, because these people are hooking up, they're not using condoms because they're not worried about pregnancy. And so there is some concern, too, that as the sexual landscape changes, that these women are at different risk for cervix cancer than they were in previous generations. So we just did a pilot study where we wanted to look at the association of health status, sexual behaviors, and cervical cancer screening beliefs in women over age 65. So we actually did a Facebook study. It was just a cross-sectional survey that targeted women over 65 years of age. We asked for their self-reported sex history, their self-reported health history, and then we calculated life expectancy based on the validated Lee-Schoenberg index. So we took what they gave us about their health and put it into this calculator. And women who completed the survey were entered into a drawing for one of 10 $50 gift cards. And so what we found is we ended up 76 women responded to the survey, 49 actually completed the survey and were included. So it's a small survey, but at least gave us some preliminary results. We found that most of them were just over the age of screening, so 69% were between the ages of 66 to 69, but we did get a number of women who were over age 70. The majority were well screened prior to age 65, so this is a population that actually probably, at least per their report, could stop screening. The majority were subjectively healthy, and they had a mean calculated life expectancy of 19 and a half years. So again, kind of that average. If you're 60, 20 years, somewhere in your early to mid 80s. We looked at how many had discussed cervical cancer screening cessation with a healthcare provider and found that almost half had discussed this with their provider. Of those who had discussed it, 43% did not agree with the cessation recommendation, and actually of those, 80% favored no stopping age. We then looked at their subjective life expectancy and then calculated life expectancy. And so we divided up 6 to 10, 11 to 20, and greater than 20 years. And the reason we divided it up that way is because that's how the Lee-Schoenberg calculator actually divides it up. And what we found is that on average, their subjective life expectancy was actually pretty similar to their calculated life expectancy. So women were pretty good at guessing how long that they would live, at least based on this validated calculator. So then what we wanted to look at, our hypothesis was that women who were healthier would be more likely to want to undergo screening, thinking, okay, I'm going to live for several more decades. I'm still worried I could get this cancer, versus women who were sicker, maybe not worry about it so much. And we found that life expectancy, both subjective life expectancy and calculated life expectancy, was not associated with desire to continue screening, but that actually, interestingly, those who were subjectively thought they were in poorer health were more likely to want to continue screening. Now, again, these are small numbers, but it was actually surprising to see that. The other thing we looked at was lifetime number of sex partners and number of sexual partners in the past 5 years. Again, thinking, okay, those women with new sexual partners or multiple sexual partners may be more enthusiastic about continuing to screen. And we found that, at least in this small survey, that there was no correlation or no association. But what you do see is that a lot of these women have, either during their lifetime or even in the last 5 years, have had multiple partners. I think that's something that we have to think about, because we often don't think about the aging population that way. So future directions, we would like to do a larger study to validate the findings in our pilot study. I think that places that we could go are oversampling of populations more likely to be engaged in sexual activities in some of these older living communities. We did not validate their reported health status with their medical records. And then looking at even sicker populations. So I think one of the things with the Facebook survey is that women who tend to be online tend to be healthier. And potentially these are the women that should be screened. I think it would be interesting, especially with our finding that those who actually felt like they were sicker wanted to be screened more, is to explore that further. And I think that, in this age of, shared decision making, we really have to look at, do we also have to look at health status in screening this population? So the last area that we've looked at is lack of knowledge of the guidelines, because this has been cited several times as reasons for why people don't follow the guidelines. So we actually designed a best practice alert for the EPIC electronic health record that triggered whenever a screening Pap test was ordered in women under 21, over 65, or post-hysterectomy. And we just chose that population that's not supposed to be screened because that was the easiest one to target. And when providers saw that alert, they either had the option to accept the BPA and it would cancel the Pap test, or to override the alert. So this is just what they'd see. So they'd put that order in, it would say Pap is not indicated. They could click here and they'd link actually to the ASCCP guidelines. Or we asked them for an acknowledgement reason, although they were not forced to put one in. So some of the reasons that they could choose to override it. So immunocompromised patients do not follow these guidelines. Those who had DES exposure, history of high-grade dysplasia or abnormal previous testing, inadequate previous screening. So again, women who have not had adequate normal screening before age 65 do not get to age out. Cancer surveillance, and then we put the catch-all other. Unfortunately, we found that a lot of providers did not answer this, and most of the time when they did, they just chose the top one, and it didn't even correlate to the medical record. We originally proposed the study actually as a group randomized trial. Unfortunately, Fairview had a problem with this because they thought it was unethical. They thought that if we put this best practice alert in for some, that because it was sure to improve adherence to the guidelines, that was unethical. So instead, we did a pre-post analysis. So what we did is we actually implemented the BPA for 3 months, but it was actually not seen by the provider. So it would fire in the background. The provider never saw anything different when they were ordering the Pap test, but it would be picked up by the analytic platform. And then for the next 3 months, we actually activated it so they would see the guideline that I showed you. And then we did a manual chart review on everyone in the 3 months prior and the 3 months after. We looked for the reason for the Pap test, workflow, the clinic location, and specialty provider information. And then we used descriptive statistics, and then we compared test ordering by intervention period, provider characteristics, and used the standard p-value of less than 0.05 as statistically significant. So what you'll see is you've got the pre-intervention period, so the 3 months before and the 3 months after, and you'll see, first of all, the number of Pap tests did not differ significantly. Provider age, provider characteristics were very similar in the two eras. So just over half of providers were female. The majority, 3/4, were physicians. Just over half were gynecologists. Now, what did surprise us, and probably just because of the way the people who were involved in this, we've been entering our orders, but we found is that over half of the time, the medical assistants were actually entering the orders, which could have some implications for our findings. We looked at the reason for the trigger, and so you can see that age, at the time, both pre and post, was not significantly different. We looked at whether the Pap tests were indicated, and you'll see that there really was no significant difference between the pre and the post intervention. And then we also looked at the action taken. So reasons that people would cancel it, even before the intervention was seen, is that what we realized is a lot of orders are put in before the patient even shows up. So when the patient doesn't show up, that was kind of what triggered it, so it would be canceled. Or maybe it was entered and it turned out that the provider realized that they really didn't need a Pap test and canceled that order, even though it's part of the health maintenance bundle that was put in. But what we found is that pre and post intervention, there was no difference in the number or the proportion of canceled orders. This is the reason for Pap tests. So, this was kind of our catch-all when we could not find any other reason, was routine health maintenance, and that was the majority. And we had a smattering of other reasons, including abnormal test results. And although there were some differences pre and post as far as more or less, if you look at the proportions, overall it was the same during the pre and post study periods. And so then we looked at, are there provider characteristics or intervention characteristics that made a difference? And, unfortunately, our BPA did not make any significant difference in ordering of a guideline at non-adherent Pap tests. And the only variable that seemed to make a difference is that actually male providers were more than 2 times more likely to order guideline adherent tests. And we actually found that in one of our previous retrospective studies as well. So who is ordering guideline non-adherent Pap tests? So we actually looked at this, and what we found, surprisingly, and this was not seen in our previous retrospective chart review, is that 45% of tests were actually ordered by 5 providers within 1 clinic. So there was 1 clinic specifically that tends to test everybody every year, starting as early as age 12 and continuing indefinitely. The 94 remaining tests were ordered by 77 providers, and there were 64 providers who ordered a single guideline non-adherent test. So that suggests that overall, a lot of the providers are actually now in compliance with it. There can always be reasons that you order 1 or 2 tests, but that there's 1 clinic in specifically that, for whatever reason, believes in screening more often. We unfortunately actually had originally proposed focus groups and looking at, because we really want to get at what are the barriers to following the guidelines. Unfortunately, healthcare providers are actually really difficult to engage. You can't pay them enough. You can't. For their time. And so we tried, I don't know how many different ways. I tried getting the clinic managers involved. I tried bringing them food. And nobody wanted to talk to me about their Pap testing orders. So that remains a mystery. But I would really like to talk with them because I think that there's, it's not just lack of knowledge of the guidelines at this point. As of, I think this was 2014, 2015. So in conclusion, clinical decision support within the electronic health record did not improve adherence to guidelines in populations who should not undergo screening. And again, about half were ordered by a single clinic. So I think that this begs the question on whether there really is a need for system-wide intervention, or maybe this is the wrong group. Maybe the non-screening population is the easiest one, and that maybe some of the intervention would be better suited for management. I think this is especially going to be true as they come up with the newest management guidelines, which are going to actually become more complicated than they already are. So for now, we're going to put aside the EHR intervention because our test was negative and we don't really know where to go with that. But we're going to look at a few other things. So one of the other populations that I think is up for question is what do you do with these women who have had HPV vaccination? So our vaccination rates have been disappointingly low in this country, but are increasing. So currently, about 68% of individuals who are eligible for vaccination have started it, and somewhere around 48% have completed the vaccine series. And Minnesota is right at that average. So about 49% of adolescents who are eligible for the vaccine have received 2 to 3 doses of the recommended vaccine. And one of our, so when you look at test statistics afterwards, as the prevalence of high-grade dysplasia decreases, you expect your positive predictive value of any test to decrease as well. Now, we do have some evidence of that in populations that are much better screened. So places like Australia, Canada, where they have school-based vaccination, where they're already seeing a decrease in their positive predictive value of their tests as well as their dysplasia rates. But we can't take those rates and apply them to the U.S. population because our vaccination rates at baseline are so much lower. So we're actually going to do a study, within the Fairview system just to look at what the test statistics are in those who have been vaccinated and who haven't. One of the other problems that we've had with previous studies is that a lot of times we count people who have had just one dose of the vaccine as vaccinated, and we don't really think that's adequate. So we want to look at, how many doses of the vaccine are needed, what's the difference, whether you've had, fewer than 2 doses or more than 2 doses, and then age. So as much as the vaccine has been approved for women or for individuals up to age 45 at this point, there are several studies that show if you get the vaccine, if you're older than 20, that it's really not that effective. So looking at, do we have to have different screening recommendations for those who are over 20 when they get vaccinated versus those who are at the optimal age of 11 to 12. And then one of the most interesting things, I think, is how do we roll out the next set of guidelines so that people actually adhere to them? And I think one of the biggest problems is that when the last set of guidelines were put out, we thought everybody would be happy about less screening, providers, patients, and the like. And we found out that there was a lot of resistance. And so we're actually proposing a qualitative study to look at the acceptability of decreased cervical cancer screening and its impact on preventive health care. So as we increase HPV vaccination, it is possible that young women will only have a few cervical cancer screenings throughout their life. They might start at age 25 or 30. They may only need a test every 10 years. And so how, accepting are people of this? Is there going to be this big backlash against it? We'd like to engage providers as well, but we failed last time, so we're going to focus on patients, at least to begin with. And the other thing is that we have often coupled other tests with the cervical cancer screening test. So for a long time, we were saying that if you wanted birth control, you had to get a Pap test. We found that was not effective because people just didn't get birth control. The other thing that we're finding now is that actually chlamydia screening rates are going down. So for sexually active women between 20 and 30, it's recommended they get chlamydia screening every year. We're finding chlamydia rates are actually increasing, but testing is decreasing. So the other thing we want to look at is what other preventive health care is being coupled with cervical cancer screening. And if we decrease it in this young woman population specifically, what other preventive health care measures may we be missing? And are there ways that we can increase that? So whether it's self-testing at home, just dropping off a urine sample at your test without seeing a health care provider, and what does that mean for missing other things that maybe are only found on exams? So that's the other place that we want to go, is really looking at how do we involve the patient in all of this and the shared decision-making and get them so they're not getting over-screened on one end but not then subsequently being under-screened for other things. So I'd like to thank you for your attention. I'd like to thank my mentors and collaborators and the funding sources, and I'm happy to take any questions.
Deanna, can you expand on, make sure I understood you correctly about the gender differences in following guidelines for the provider gender differences?
Yeah, so what we found, and this we found in our retrospective review specifically for women over 65, is that male providers are actually much more likely to overscreen than female providers. And we're not, again, unfortunately, we have not been able to engage healthcare providers to find what that is. I'm not sure if it has to do with that woman because they also have to undergo their own screening, are more likely to be up to date on the guidelines. I think a lot of people who have a specific interest in women's health care tend to be women, not across the board, but that does, and so I think that if that's your specific niche, you might be more up to date on the guidelines. So we don't really know, but that's just some of the things that we've thought of.
Can I ask a question about where did the guidelines come from? And I'm asking that because, at least in the world of mammography, a lot of the modeling was based on old randomized trials where people were screened or not screened, so they could get an estimate of what the benefit of screening was. So a lot of people that don't follow the guidelines basically don't believe the modeling.
Yeah.
So
it's similar. We don't have as many randomized controlled trials, so most of the data actually are based on Kaiser data. So I will say that the Kaiser data is based on very well-screened and treated population. But what they do have is they have, hundreds of thousands of women in these databases, and so they can look even at, years out. They can break it up by HPV type. They can break it up by Pap test type. They can look at, 1 year, 2 year, 3 year, up to 7 years. What's their risk of developing high-grade dysplasia? But I think that one of the problems is, and we're actually, so ASCCP is actually developing their new guidelines now. And one of the concerns that comes up is, what if you don't have that population that, so Kaiser, because it's, people are not, you're not going to find these abnormalities and not treat them. So what happens if you find them and don't treat them? So there are other databases that are being pulled in, but the best data, unfortunately, we do have is that well-screened population with some supplemental data from, some less screened populations.
Other questions?
I'm just curious, you kept stating that the current guidelines are confusing, that they're going to get more confusing as we continue. What do you think, just like a prediction, if we were to make it so that the guidelines are understandable not only to patients and their doctors? Like, I guess I'm just curious as to, like, if we make it more confusing and it's already hard to follow,
right.
That seems like we're just going to, like, continue down this same spiral.
Yep.
And what the benefit of making it maybe clearer, that cost and benefit of, like, what the risks would be to that.
So I think that there's a lot of discussion, at least in ASCCP, about that exact topic. The problem is that there's multiple ways to screen, and the other thing that's coming up is it's not just that one test, but it's your history. And so I think what they're trying to get at is this very specific risk calculator that takes into account not only your current test, but also previous tests. Because if you've had multiple abnormal tests in a row, or that persistent HPV-16 infection, you're at much higher risk than someone who's had that single abnormal test, or maybe a different HPV strain. And so I think that you're right. It's a trade-off between really coming to that specific risk for a specific patient based on their current testing, their previous testing, which then increases the complexity of the guidelines. And what they're proposing now is that right now what we have are algorithms. So there's an app. You can also just go on. There's a PDF on the website where you follow it down the algorithm. What they're proposing is there's not going to be an algorithm, so there's going to be so many different. So you're going to have the app. They are going to develop it for Epic as well. But again, it's going to take time, right? And I think that anyone who's a clinician knows that the more you ask somebody to put in, the less likely we are to do it. So I do think there's a trade-off. I don't know exactly where that is, because I do think, too, as an oncologist, we see the cancer, which we want to prevent. But we also see those women who are coming to us with essentially no cervix left. And when they're young women especially and want to have kids and now have this high-grade dysplasia, it's like, you really didn't need those first 2 excision procedures. So I think there's a trade-off somewhere, but I agree. I think it's going to be hard to find that sweet spot. I do think that there's a difference in the way they could have been rolled out. So these are just kind of introduced, like, ta-da, here they are, here are the new guidelines. They're based on really good data. And I'm on one of these guideline committees, so now I understand in a new way how they were actually made, but I don't think the general public did. I don't think the providers did. And so I think part of it's just going to be that education, too, to really understand it. But I agree. I think that's the hard part of what's being proposed.
I'm reminded a little bit of what happens or is happening with prostate cancer screening, where we used to do all these annual screens, and then rolling it back is a really tough thing to do. Yep. It's tough on providers, but it's tough on patients. Even the differences by race and the burden of disease. So it's not a simple thing to be a good doctor and not do something. Right. So I wonder if people are sort of studying the kind of health communication aspect of this and what is a good approach, because I think everybody knows the abstract idea that you could be harmed by screening, but in general think, well, that's not what's going to happen to me. I'd rather be on the safe side and just do this. Yeah. So are there I don't know, theories or people on the social science side of things that are looking into that?
So that's actually where we're kind of veering into, is to try to look at that and to look at what are the specific, either where was it miscommunicated from the guideline level, what are the specific fears, what are the things that we need to address, or what are real concerns that maybe haven't been thought about when you're looking at it from a very academic standpoint. I do know ASCCP has an actual communications group this time that they didn't have last time, looking at exactly how do you roll out those guidelines, because we know that it was not well rolled out last time. I don't know the specifics of what they're working on, but I know that they're paying more attention to it. But that's something that we're hoping to get into. I've got a collaborator in the communications school here who's helping me with some of this as well, because that's actually become more of it. It wasn't my interest when I started this project, but as I've gotten more into it, that's become more of an interest. And I think especially looking at this young woman population for whom the screening guidelines are going to change. And And again, I think as we, include HPV vaccination history, it's going to become more complicated. And then figuring out who really has been vaccinated, who hasn't, and who knows if they've been vaccinated. That's the other part of it.
All right. Thank you very much.